call the joint meeting of Ways and Means and Consumer Protection and Health to order. Good afternoon. So I guess what we'll do is we'll start off with, you can tell us some of the changes in the budget and then how you think the federal, the federal cuts are going to affect you.
Yes, we'd be, aloha. Good afternoon, Chair Dela, Cruz, Chair Baker, and members of the Joint Committee on Ways and Means and Commerce, Consumer Protection and Health. You have our written comments. I'm not going to read those, but I would like, if I might, just hit some highlights of accomplishments this year, something beyond what you read in the news and hear on TV every night. Some major accomplishments that I'm really quite proud of that we've done this year, and then we can get into any questions you have regarding federal funding and those kinds of things. We continue to be guided by our Department of Health Strategic Action Plan. I think you're all familiar with this. So we've got copies for those who may be new to the committee, and we're happy to meet with anyone who needs further briefing in that regard. We've made great progress in all areas in our Strategic Action Plan, especially related to joint efforts with the Department of Human Services on Ohana Nui, which addresses root causes of poverty, poor health, and adverse childhood experiences. And some examples of those joint efforts are home visitation, addressing the social determinants of health, the one key question, and the screening brief intervention and referral to treatment that we explained last year and we've been busy implementing. Our joint efforts with the Department of Human Services and the University of Hawaii on the all-payer claims database, which we're now calling the Hawaii Health Data Center, is another major collaborative effort, and you'll hear more about both of these from the Department of Human Services, so I wasn't going to go into more detail on those now. Other major accomplishments this year include our telehealth initiative and our statewide opioids substance use disorder strategic plan. We thank you to the legislators who were active in those initiatives with us. We also completed our joint Hawaii mosquito-borne disease outbreak emergency operations plan with the Hawaii Emergency Management Agency, the Centers for Disease Control, and the counties. And this plan becomes a template for addressing other public health emergencies beyond mosquito-borne disease. In addition, we've made major progress on the Hawaii State Hospital new forensic facility. The award date for the design-build contract is expected to be around January 16th, this month, a few weeks, and with the groundbreaking expected to be by the end of this summer, and the estimated completion date still December of 2020. One caveat related to the new building is the recent PRU approval by the City Council, which added a stipulation that, quote, prior to January 31, 2018, the applicant shall, one, seek funding from the state legislature to finance the entire campus to be a fully secure hospital facility, and two, to submit evidence to the council that we made this funding request. So we must follow up on this. This request will be submitted as a governor's message once we've had an opportunity to determine the scope and cost of that request. Looking forward to the coming year, we plan to continue our strategic action plan, especially in telehealth and the opioid substance use disorders, the Hawaii Health Data Center, Ohana Nui, and rebuilding our community-based mental health capacity. We also plan to develop a strategic plan, including a sustainability plan for medical cannabis regulation and patient registration. Cesspools will be a major issue to address to prevent the threat to our drinking and recreational waters. We also have Centers for Medicare Services dedicating a federal team and an independent private consultant to help us with our compliance issues related to the certification of health facilities, including skilled nursing and dialysis centers. Our greatest concern going forward is potential cuts in federal dollars, as you mentioned, Chair Dela Cruz. Congress and the President passed a sweeping tax cut, as we all know, but they have yet to determine how they will fund the resulting deficit. What we have heard to date is that this deficit will be funded by cuts in public health, prevention, preparedness, social services, Medicaid, and especially environmental programs. In our detailed overview, we have highlighted the programs that are at greatest risk. In anticipation and working with our programs, we have defined the impact and assessed which programs are most core to public health. We are, and we'll go through any of those that you have a question on, but we're asking for a change from federal funds to general funds for a few areas. One is an environmental health specialist for water pollution control enforcement, and 2 environmental health specialists for supervision of the underground storage tank section. This request totals about $202,000 in general funds. As we continue to encounter the increasing need for public health services and the need for 24/7 response with fewer resources, including anticipated federal cuts, our electronic and online public access is more critical than ever. We need to encourage better use of our website and online resources by the general public. In order to accomplish this effectively, we must have a dedicated individual skilled in social media and a website that is maintained to be up to date, accessible, and easy to navigate. This is the basis for our request for a new communications FTE. The Family Health Services Division, Early Intervention Services, is requesting additional general funds to meet the rising costs of providing federally mandated early intervention services. That is about $2 million. And the Adult Mental Health Division is requesting to convert 42.5 temporary general fund FTE positions to permanent FTE positions. This is to assist us in the recruitment and retention of employees in the Oahu, Maui, Big Island, and Kauai community mental health centers. The duties and responsibilities for these positions are of a permanent nature. Our total new requests for fiscal year 2019, being supplemental budget year, are minimal. 12.6 new general fund FTE, including the 4 that I've just mentioned, and $13 million in additional general funded resources, almost half of which, or $6.1 million, is for second-year funding for the Executive Office on Aging, and that's for their aging and disability resource centers, their Kapuna Care, and the Kapuna Caregiver programs. We are also requesting $14 million for really critical CIP projects. So I thank you for the opportunity to share our proposed supplemental budget for fiscal year 2019, and we're happy to answer any questions you might have. Thank you.
Any questions? Can you outline the federal cuts?
The federal cuts? Okay. Keith, do you want to do that?
Good afternoon, Keith Yamamoto, Deputy Director. We don't actually have any specific federal cuts coming down yet, but we did one back in September of 2017. We did kind of a cut scenario. We did 5, 10, 15%, and looked at our different kind of programs, asking our programs to make sure when they're working with their federal agencies to keep a keen ear in terms of any kind of hints and indications about where some of the things are coming from. So I do want to share some of the information we gathered back in September. So our total federal funding, NNP, is $202,432,000. That equates to approximately 332.46 FTE permanent and 217.25 temporary FTEs. So this is about 17% of our total FTEs in the department. So we did a 5, 10, 15% reduction, just as a means of kind of keeping programs aware about, how to prioritize what's important, what are the impacts, if you're looking at reduction in force based on those kinds of things. So we just wanted to make sure people were attuned to it and were prepared to it as those cuts evolve over time. So if you're looking at a 5% reduction, it's a total reduction of approximately 4% of 24 FTEs at 5% on the federal side. If you do the 10% reduction, it's about 68 FTEs, which is about 12% of the position. At 15%, it's 94.75 FTEs. So part of that is looking predominantly with the resources that are for positions per se, which is where the bulk of the resources generally are in as a whole. We also have some programs to kind of look back in some of their areas where they would have to consider or reassess what they're going to do based on reduced funding. So from the disease outbreak side, the possibility of reduction in surveillance functions, public health emergency preparedness efforts may be reduced, immunization for children may be reduced. Child and Adolescent Mental Health Division, the Community Health Services funded to contract for clinical coverage may be impacted. Clients may not have access to psychiatric and psychological services in East Hawaii. Under the Family Health Services Division, Hawaii Childhood-Led Poisoning Prevention Programs may be impacted. The Infant, Toddler, and Disabilities programs may also be impacted. The Environment Management section, beach monitoring notification, may be impacted as well. So I think what we tried to do in September is saying, let's look at it, make sure we're keeping a tune, keep track of what's going, because it's changing almost every day. And so we haven't really identified in the supplemental budget, we looked at some positions or resources that we need to cover kind of what we thought were kind of impactful, and we had data to back up on.
Yeah, so the environmental positions that we're requesting for state funding, I believe those are existing. Those are already federally cut.
Right. The other thing we did.
They've already told you they're cutting those.
We've already had reduced funding source, so that's the recommendation for us to get them switched to state funding.
Right. So that's maybe over time versus any kind of particular action they're taking to reduce it. So over time, the reduction in some of the federal money, clearly some of the positions can be maintained, and those are the few that we're asking for currently to look at. We also did. We had a presentation back on December 15 from the Federal Fund Information for States program. I don't know if you heard of FIS. And we, Laura Johnson down at Budget and Finance did one for state agencies. And what was really helpful was it's an organization that helps states look at all these kind of federal funding issues and concerns, and maybe some of the trends and some of the patterns that they're seeing that may impact the state. So back in December, we were able to get a presentation predominantly on kind of the programs we had in the state. So again, they're talking about maybe some of the trends, some of the things that maybe if there's alignment between the federal, different federal agencies and the present budget, that seems to be an issue that they're suggesting that we kind of keep track on. So I think overall for the department, while we don't know exactly where the cuts are, we've been kind of cautious and aware that we should be looking at it, being consistent in terms of what is it we're seeing from the maybe the project officer side at the very lowest level from the program, what they're hearing from their funding agencies as they know, and be prepared to look at when these cuts based on that 5, 10, 50% reduction, what do you think you may want to consider that you may need additional funds to support.
So we know there will be cuts, but we don't know for sure. So this is a heads up to you so that you can be aware as we are, and we've done the analysis on where our greatest risks are so that we can be prepared to determine what things are absolutely essential that we're going to have to come up with additional new sources of funding.
And I think you all have been clear regarding coming in for state money, that it's not just we lost the federal money, we want state money. So part of the process is looking at where those reductions are. Do we, as a policy call, do we continue doing those things with state money or not? And if so, what's the priority in terms of asking for additional resources? So I think the department will continue to kind of keep tabs on it. I think in the supplemental year, we were mindful that we're coming in for things that we know we have information and facts in terms of impact on the programs based on some kind of over time reductions, but there hasn't been any indication about any kind of significant cuts that we know at this point that we could come in and say, here's what's going to happen and we need resources now to address it. So I think the strategy within the department is to keep on top of that, keep you all informed as those things evolve, and hopefully there'll be a clear picture in in the biennium year to come in to say, here's where we think the PUCAs are, here we think that we want you to consider as a policy call to support, because we don't have federal money, and ask for your support on those.
So the requests we have made are real needs, and then we will keep you informed regarding the other potential threats to federal sources of funding.
And the federal funds that you're concerned about are not competitive grants. Those are like block grants or things that the feds have traditionally funded.
Right.
Basically all of the states that had those issues, correct?
Correct.
Yeah. So they tend to be, the discretion money we're just surmising that, you competed for it. It's time limited. It's probably easier for them to just let it run its course rather than trying to reduce it.
Those cuts haven't been made yet, but we know they have to balance the budget somehow. So they're things that have been put out there as potential sources to fund the deficit.
Right. The one thing that we've noticed that they have not been generous in allowing no-cost extensions. Yeah. So if you haven't used the federal money, there's a pattern, because it takes time to implement programs, we ask for no-cost extension with the current money. Those tend to be a little less available, or they're saying they're going to scrutinize those more because there's a concern about whether those programs in fact should be supported. So I think we're just mindful that, okay, well, we traditionally had these no-cost extensions. That may not be the case.
And that's why we're working so closely with the Department of Human Services. We have to be smart about limited resources, and we're all focusing on the same issues in the communities, and also working much more closely with the private sector, the hospitals, the communities, so that we can bring health care and public health, they're kind of merging a little bit more than they used to be. They used to be very separate. And I think as resources diminish, we're just going to have to be smarter about how we work together collaboratively with everybody in the community.
Right.
And the areas that have been potentially targeted for cuts, there are warm bodies in those positions, correct?
Yes.
There are. Particularly in the environmental area, which we seem to hear a lot about some reductions. Now, Jenny and I also sit on or participate in the Association for State and Territorial Health Officers organization. So ASTO has been helpful in trying to gather us and give us kind of indications when they're hearing anything on the Hill about the budgets or where it's going, that they've been pretty good at informing us and giving us a heads up that this is something we should, states should be aware of, and then keeping us in the loop on those.
Another area that we heard this morning may be up for grabs is Attorney General Sessions is saying that he's going to amend the Obama policies, which I assume is he's meaning the Cole Memorandum. Mm-hmm. Have you folks received anything official other than just what's been in the media?
I have not. No. I'm not surprised. I expected this a year ago. Yes. That's one of the reasons we've been very careful with our medical cannabis program to make sure we're focused on the safety issues.
Mm-hmm. Yeah, I think that maybe our saving grace is that we have a highly regulated program. What are some of the areas where you have, let me back up, where you might have vacancies that people that are in these other programs, if the funding goes away and there's not a way to save them, can they slide into others? And can you talk about the reorganization that your department is undergoing?
Sure. Regarding the vacancies, I'll let Keith chime in on this, but we've done a pretty good job of trying to eliminate vacancies over the last few years. We've heard the money chairs in the past, so there aren't that many empty vacancies, but we've reduced them significantly.
So I think the department, we've been putting a lot of effort into trying to make sure that they look at their vacancies, they look at how long the vacancy's been around, and reassessing whether those positions should continue in that form or should be moved to other places in the department. So I do think that there's a request in the budget to convert some of the temporary positions to permanent, particularly in the adult mental health side. And, that's been a challenge. There are jobs that in general are somewhat challenging, working with a population that is not always the easiest population to work with, and they're temporary. So we are asking, I don't know if Lynn wants to talk a little bit more about that, for those kinds of positions it is a permanent function, and it's something that's not going to go away, and we need to have permanent positions to do those kinds of work. So on the vacancy side, that would help tremendously in attracting and keeping people in positions they feel that are permanent, that they're secure, and that they can, in fact, ensure that that's something they can continue doing. So there is some movement in terms of the budget in moving some of the temporary positions in permanent functions into permanent positions. And so there's an ask, I think, in the budget for that. The funding regarding some of the federal to state, I think, also impacts the recruitment. People know that funding on federal grants are somewhat unstable and maybe a little reluctant to apply, even if we feel somewhat confident that the funding will continue. So I think with low unemployment rates, people who are looking for work are particularly sensitive to those factors, and because they come to state government because they want to make a lot of money, right? I mean, what did my father tell me working for the state? One thing, a benefit was the security aspect of state government, right? Supposedly.
Used to be.
But so part of that is all those things that we tout and we encourage people to come to work for the state somehow gets eroded by those kinds of issues that we need to manage better to make it enticing for them to come and work for us.
And on the reorganization you're asking about, you're talking about the preparedness reorganization. When Loretta Fuddy was the director of health, she put together the public health preparedness branch. That was actually started when I was still there as a deputy, with funds coming after 9/11 attacks and worries about bioterrorism and other things. So it was put under the infectious disease area, so under the Disease Outbreak Control Division. And since then, those probably our greatest risk worldwide is still going to be like a pandemic flu or something like that. But we're more and more seeing additional risks such as nuclear radiation, spills of various kinds, and in the areas that we've had most recently, for instance, the dengue fever outbreak, that was an area that clearly crosses over communicable diseases and the vector control folks, as well as Department of Ag, and same thing with the rat lungworm. All of these things are affecting so many different departments as well as many community partners, so that the collaboration and the coordination of that, I think, deserves to be recognized under the director. So we're just taking the existing branch. We're not adding any FTEs, and that will move under the authority of the director as a new office for all hazards preparedness. And this is, I think, a very important move. And I sit on, Keith mentioned ASTO, the Association of State and Territorial Health Officers. I sit on the National Committee on All Hazards Preparedness, and we'll be having a meeting in D.C. in a couple of months. So I'm actively engaged in what are the best practices there. And so there's an empty branch chief position right now in that branch. And that will become the person who's overseeing the new office. So we're putting out right now, it's an exempt position. We'll be recruiting both internally and externally to fill that position.
Follow up real quickly on the reorgs that you were just talking about to Chair Baker. For HTH 420, I know you mentioned that you folks were trying to do the conversion from temporary to permanent to reflect some of the reorgs that you've been doing the last couple of years, and that's the request you're coming in for. But I noticed in the vacancy chart something a little bit different, and maybe it's just the way you're typing them in. But for HTH 420, I noticed that there were at least about 40 new positions that were just established. It just says new on the date of vacancy, so I'm assuming you guys just created them with an expected fill date of ASAP, and they're all temporary, so these are not permanent positions. So is this part of your reorg that you folks are doing? But I'm assuming if they're temporary, they're not part of this effort to recruit more permanent full-time individuals as well, and they're all budgeted positions as well, so you have the resources to pay them already from existing funds. So how is this in relation to the request?
Many of those positions are in our community mental health centers, which have undergone reorg. So those new positions are positions that were redescribed, so to speak. And so we're not asking for additional resources for those new positions. And the reason they're listed as new is because they went through a process of being redescribed.
You cut them very good last time, huh? Just kidding.
And so the division has been working very hard on implementing the reorganization, and this is part of that process. So we're presenting you with information about what positions that you will see listed on the information would be called new.
Okay, so this is part of that overall reorg.
Yes.
That you have.
Yes.
So you basically redescribed them over the last 3 years, but they're still temporary in nature.
Yes. Many of them are. I think on the list we've identified. So there are two parts to it. First of all, there are new positions, some of which are temporary and some of which are permanent, I believe. The requests that we have before you are for not new positions. These are existing positions where we're experiencing, because they are temporary, because we went in
and making requests for additional funds then? Okay,
no.
good.
No.
So new in the sense that it's new because they're redistributed.
I just wanted to make sure that these weren't new, that you weren't given.
Not at all. We really took a disciplined process, and we said, in order to accomplish what we need in this area, and we work with the most severely mentally ill across the state, county by county, what is our experience, and what positions out of the total do we need to move from temporary to permanent? So it's not every position. And I can outline for you county by county, and that's how we've organized the information in your Form A's. How many, what positions. It's basically because they're permanent, the functions are permanent in nature, and because we need a sustainable system.
Yeah, we're only requesting 12.6 new general funded FTEs in the supplemental budget.
Okay.
So the governor didn't fully fund collective bargaining. Can you just maybe explain to the committee where you're going to have to cut?
Good afternoon, Chair Dela, Cruz, members of the Joint Committee, Linda Rose, and Corporate CEO for HHSC. So I believe, Chair, your question is that regarding our supplemental budget request, which is based on the collective bargaining costs that were occurring with the new contract that was not previously funded. We did not receive in the governor's budget the full amount that we had requested. I have representatives of the regions here with me today, but we have not formally discussed service cuts because we are before you to ask that you fund our collective bargaining so that we don't have to do that. We have managed, you have our testimony, we have managed to increase our revenues by 6%, which I believe is quite an achievement in today's healthcare environment through hard work, but it cannot fund the collective bargaining increases because we also have to fund the fringe on top of those raises. We were fortunate to receive our request in the biennium budget. We're grateful for that, but the new round has caused increased costs. We don't feel that we can sustain the current services if we're not provided that funding. Yeah.
No, we're going to. This was a question. We're going to. Any other questions are open for either HHSC or Department of Health.
Yes, and Maui Health Systems is also here today regarding their request.
Thank you, Mr. Chair. I wanted to ask about two issues that are impacting the homelessness crisis here in Hawaii, mental health and also substance abuse. In your supplemental budget request, first of all, what level of need is there in the community for these state services? And does your supplemental budget request fully fulfill those needs?
The need is huge. No, we're not asking for new funds there, but I'll let Lynn Fallon address that.
Senator Chang, members of the committee. First, we want to thank the legislature last session for adding funds for the homeless area, especially in case management and in outreach. So thank you very much. You added that money, $500,000 permanently for severely mentally ill into the adult mental health budget. That's HTH 420. What we have in our supplemental budget request is funding to continue $800,000 in the second year of the biennium for homeless outreach and for a project called LEAD, which is outreach and it's being implemented as a pilot in Chinatown, working with law enforcement. So in our supplemental request, we're asking for continuation of $800,000 to the Alcohol and Drug Abuse Division, HTH 440, for continuing the outreach for individuals with serious substance abuse problems, and for $200,000 for the LEAD project to continue that pilot. And we have put a very ambitious evaluation into the LEAD project, especially because we want to ensure that it is effective. It's been used in other jurisdictions and has proven to be effective there. We want to have similar results here in Hawaii. And so if you have more detailed questions, I can ask Eddie, who heads the Alcohol and Drug Abuse Division, to answer those questions.
Yeah, and let me add, Senator Chang, to address your question, that we've been actively working the last few years on rebuilding our community-based mental health services with existing resources. So that has not been a new ask, right?
Yes. Over the years, we have looked at different ways to rebuild the community mental health system. So we've added services so that individuals can be effectively served in community settings. And we're also looking not only on Oahu but across the state, working with law enforcement and nonprofits to begin to expand mental health emergency worker services and MH1 services, especially for law enforcement and nonprofits as they're working with homeless individuals and may show up at ERs. So there's a lot underway. That's one example. We're looking at putting out the RFP probably in January for what we call secure diversion services. So individuals don't show up at the ER and can be diverted from the hospitals.
Yeah. And then in addition to that, the opioid substance use disorder strategic plan, that's being funded with federal dollars that Eddie Mercero has obtained. So that's a collaborative effort with the community, and we're doing everything we can to work together with others.
We do have a request for the Alcohol and Drug Abuse Division. And it's not a request for additional resources. It's a request to raise their drug. It's DDRA. I'm sorry, I don't remember what it stands for. But it's a special fund funded by fines for individuals who use drugs and get cited. And so we're asking for about a $250,000 request to fund things like opioids and meet some of the substance abuse needs in the community.
It's a ceiling.
Yeah, it's a ceiling request. We're just asking you to raise the ceiling.
Yeah. And then going back to our strategic strategic plan, the screening, brief intervention, and referral to treatment, and the one key question, which I'm happy to explain further if you're not familiar with them, are ongoing efforts to try to get way upstream to identify early on individuals who are at risk and those who actually have a problem with substance use, and particularly impacting young families and pregnant women. So that's an ongoing effort to really try to get at this upstream.
Out of the total population of homeless persons with mental health needs and with substance abuse needs, what percentage are currently having their needs met by your department?
I can tell you that not specific to the homeless. I can, our community mental health centers and our adult mental health center POS providers statewide in FY17 served about I believe it's 9,000. I actually have the figures here. Hold on. But that's how many we serve. Obviously, the need is great, and we need to continue to focus on rebuilding the system and the services that support them. So we have looked at what resources we have, looked at the data about what's missing, and part of our proposal to you to the 2018 legislature is how we not only rebuild, but we sustain that. And that's why we're asking for the positions in the community mental health centers to be made permanent. And that would be statewide. You might want to
just mention that the bulk of the services that the department provides to the community is through either GIAs or purchase of services, that the department itself doesn't provide direct services in the areas that you're asking about. They do it through community providers.
Each of the behavioral health divisions, which includes alcohol and drug abuse, purchases all of the direct services for treatment and for prevention. They have a very small division. They partner with MedQuest and the private providers to deliver substance abuse treatment. Our child and adolescent mental health division and our adult mental health division, what we say make and buy services. So we have in every community across the state, every county, what we call either family guidance centers or community mental health centers that are kind of the hub and are there when services are needed for the most severe and persistent that no one will else serve. Those are state delivered. And then we purchase substantial number of services both in the children's area and in the adult area, partnering with purchase of service providers. And it's in that mix that we're able to sustain during times of crisis and then do very proactive outreach where we can. So, we try to leverage resources. And they, in turn, work with our divisions to look at different ways that we can begin to fill some of the gaps and meet the needs.
I appreciate the hard work, and I appreciate that there may be many avenues through which resources are channeled to these needs. But as you already stated, the needs are great, and in this plan, or is there anywhere else in your department, is there a commitment to meet 100% of the unmet needs of individuals in this population, which, after all, have attracted so much attention from the press and from our constituents?
You're talking about the homeless or the substance or the mental health, or both?
Homeless persons who are suffering from either mental health or substance abuse diagnoses.
We've been working, Senator, very closely with Scott Murshigi, the homeless coordinator, and with MedQuest and the insurance community through MedQuest to try to look at how we can meet all of the needs in our community. we need to work together on this. There's no one entity that's going to be able to do it itself. And so we use the term link and sync, and that's something that our ADAD chief kind of has coined, which is, given the need, how do we work together to meet the needs in the community? Because no one entity, state government, can do it by itself. So it's going to take that kind of cooperation and that kind of coordination and alignment that's going to enable us to meet the needs of the homeless population.
Yeah, so there's a Hawaii Interagency Council under Scott Morishige that includes multiple departments, includes some legislative representation, and that's under the department. Scott Morishige's under the Department of Human Services. So we're a piece of that. And then on the bigger mental health piece, it is multi-pronged. We serve generally the seriously mentally ill, but with this new federal grant that Eddie's been able to get on the screening, brief intervention, referral to treatment, it allows us to really start working upstream also on prevention and early intervention. But as far as meeting the needs across the entire spectrum, we're a long ways away from that. But at least we're making a dent in it.
Thank you.
Senator Tokuda, did you have a follow-up? Yeah, can I follow up? I was looking at the restrictions table, and I'm hoping that perhaps you got some restriction relief at some point on some of them.
Yes.
Especially, and I'm pointing out HTH 420. I noticed a $2.5 million restriction on adult mental health division. Did you get relief on that one specifically, by any chance? And even ADAD. We've been having a lot of conversations right now about dual diagnosis individuals, people suffering from chronic homelessness and maybe drug abuse or mental health issues. Have you seen any relief restriction on these two areas? I'm not saying the economy is doing good. We always can do much better, but when you're talking about close to $1 billion in reserves going into the next fiscal year, to have $2.5 million restriction on HTH 420 and then $400,000 in 440 for ADAD. In addition to that, my concern is if you take a look at the interdepartmental transfers, I know 420 took a hit to the state hospital because you're going to be moving $400,000 to build them a fence, which I'm sure my constituents appreciate the fence, don't get me wrong. But when you total up the hit then to adult mental health and community-based care, which really is about trying to make sure that we can have another alternative to the state hospital, which on a daily basis, the census is always pushing over 202, right? That's the constant question we have, which is a concern for safety, for patients, for staff, for everyone there. And you have to report that to the feds whenever we go over that number. You'd want to have that community-based care as an option. Again, it's the continuum. It's that option to provide people with care from the streets. So do we have that restriction relief in that area? Why are we diverting from there? And how are you making sure that money is not taken away from the spectrum of mental health care for people, especially community-based care?
Thank you, Senator. So we are preparing as we speak the request to release. Normally there's hard and soft restrictions, 7 hard, 7 soft.
Okay.
We're going to try and shoot for the whole 14. We said with all the things that are happening in the different programs, we do need to collect for budget and finance all the justifications, the cost of the fence, and all those wonderful things that are coming immediately that we think we can use the resources for. So the plan is, as we speak, to collect all those program information to figure out what the priority is in regards to the release and expend that money currently to meet those needs. So we are in the process of gathering that information.
Because I think definitely while there are many important things on the restriction list, some definitely rise to the top over others. So whether some should be expedited. So for example, to look at CAMD. CAMD's been something we've talked about for the last few years, especially looking at the reimbursement rates and the provider rates. That's something the legislature pushed really hard on last year for the service rates to try to increase that. If you look at the justification on that one, in fact, it says here, and I think there was even some publicity about that, we lost a hospital provider, one of our hospital providers.
Queens, I think it was.
And I'm not sure was it because they could not get an increase in the rate, because later one of the other providers, we only had 2 that was a hospital service provider, I think, right? Already our adolescents we're already kind of at a tight place with all of them, especially when we look at CAMD, right? And we've had many discussions on this for years. We've even talked about audits in the past. We've talked about how we're going to continue this delivery of service. We don't want it to get to acuity because then they become adults with mental health needs. How are you making sure that money first doesn't get restricted? You actually get the money you need to be able to get the service providers the increased rates that they should be getting. But I want to make sure this restriction didn't result in us not getting the money to the provider and resulting in them pulling out. Please tell me that this restriction was not the reason why we lost a provider.
We have been working with
because that was $500,000, I think, in the restriction.
The hospital, so it's in the hospital-based residential area, and we have two providers, or had two providers, Queens and Kahi. And when in our meetings with Queens, we negotiated an increase, and the increase that they were asking was beyond what we felt. And so to ensure that if we didn't lose capacity, Kahi is accepting those patients, those youth. So we haven't lost capacity. What we tried to negotiate is to come to agreement about rate and increase. And the increase that they were asking for exceeded what we felt based on review of rates we would pay. So we didn't lose capacity. We kept within what we felt was responsible in terms of rates. And Kahi has stepped up to work with us to fill and ensure we didn't lose capacity. I don't know
the
if
rate increase was beyond our authority, I believe, to pay, was it not?
Well, the rate increase was substantial. And
that they were requesting, or that we were?
That they were requesting. So you reach a point in the negotiation where if we are not going to lose capacity, and we'll continue to look at this, but at some point we have to make a determination about what would be a reasonable rate increase.
But no child was slipped through the cracks in terms of because this provider went off the market. And I think when we'd had this discussion about providing this increase pot to you last year, one of the discussions I recall having was making sure that there were no gaps, knowing that this was the plan that you folks were going in with, knowing that all the providers that service CAMD weren't necessarily going to be served with additional funds, and that increases had not been given for the last 10 years.
Yes. Capacity for hospital-based residential. We appreciate Kahi's willingness to work with CAMD, and also thank the legislature for supporting the rate increase and adjustments from last session. So we could continue what we had in place.
So how long is it going to take to get the paperwork to BNF or to the governor's office to get those restrictions taken away?
So we want to get our budget stuff in this week. So we're going to be working on the coming week to get it out.
Okay.
And then the programs to get the information
The
in.
Committee on Commerce, Consumer Protection, and Health, jointly with the Committee on Health from the House side, is going to be holding an informational briefing on some mental health issues, some of them revolving around the hospital. That would be a perfect opportunity for us to get an update on whether those funds have been released. And so be assured that you will get that question at that hearing.
Next Friday.
Yes.
Okay.
Just make sure staff heard that. Right?
Hopefully the fifth floor heard it as well. The other question that I'd like a little bit more information about is your efforts to divert from the ER, most prominently Queens, into other services so that they're not either having to eat a very big bill, or we're not having other places have to pick that up. So can you talk a little bit about where you are with the secure diversion from the ER and what your plans are to make sure that we have other things available, and we're working with our ambulance services and others, police and others, to know where the appropriate place is and not just dump everybody at Queens.
Good afternoon, Chair Baker, Chair Dela, Cruz, Senate committee members. Mark Fridovich, Administrator for Adult Mental Health. In the years from 2013, 2014, we've been rebuilding adult mental health community-based supports. Those have been done for a number of reasons. One, in response to the cuts of 2009 through 2012, and another in response to the incredible increase in rate of admissions to Hawaii State Hospital and the follow-on extremely high patient census there. We started with crisis services and crisis supports and beefing up our crisis line of Hawaii, formerly called the Access Line. And we've been successful in stabilizing those 2 or 3 very important community-based services. Our next set of endeavors have been to try to address supporting our community mental health centers, completing the reorg, fully staffing our community mental health centers, and hence the request before you today to convert about 43 of those positions from temporary civil service to permanent civil service, and to fully staff our court evaluation branch, which was besieged by a large number of court-ordered evaluations in that interval. On the purchase of service side, we expanded homeless outreach across all neighbor islands and have started 2 targeted intensive case management programs, one specifically focused on individuals brought to the attention of Honolulu Police Department, either in their central receiving division, jail, lockup, or because they're being referred to an ER, Queens, Castle, Tripler, as an MH1 individual. It's called Homeless ICM, Homeless Intensive Case Management. We do it through a purchase of service provider. It's a small-scale program that uses information in a homeless outreach provider to leverage that information and target individuals who are homeless, not previously attached to adult mental health, not attached to Ohana CCS, and at risk for being arrested and going to an ER. Very important, very promising program, small program, and we seek to build on its strengths and hopefully expand it across the rest of Oahu and maybe on neighbor islands. In addition, we are procuring, I'm hopeful this month, Secure Diversion, an intensive residential program, community-based, that will constitute an alternative to inpatient treatment for individuals ordered into the custody of the Director of Health, but who really don't need inpatient-level clinical supports. These might be individuals who were on conditional release, who violated the terms of their release, and need to be someplace in custody, according to law, but really who don't require inpatient treatment. Procuring such a service, it's new in Hawaii, it's a challenge. It's a challenge on the rate side, it's a challenge on the provider side, and it's a challenge on the siting side. It's not every site that would be appropriate for such a program. It needs to be big enough to support an economy of scale, but not so big so that it's just an institution by another name. And these challenges, I believe, have been substantially overcome. Whether there's a willing provider remains to be seen, but we're hopeful and optimistic that this kind of program will make a difference, divert people from inpatient treatment, divert people from Department of Health custody, and provide an alternative in step down for individuals currently at the hospital who no longer need that level of care.
And the other question, I think you were asking about the burden of admissions to Queens and Castle as well, get the brunt of the mental health admissions. So we have started a whole process on MH1, MHEW with all the hospitals needing to be ready to...
Yeah, thank you, Director Pressler. I can expand upon that. We've had a reasonable system on Oahu, but the bulk of the responsibility has fallen to Castle, Queens, ER, and Tripler. In October of 2012, the program was extended to 3 or 4 other facilities on Oahu. We're revisiting that and trying to rebalance the allocation of those mental health 1 transports. Those would be police taking people at need to an ER for assessment on Oahu. In addition, we met with the Healthcare Association of Hawaii and some of its member hospitals, and we're looking to extend that program statewide to our neighbor islands as well. It's an area where we seek greater conformity with the law. The law here is HRS 33459. So we think that it's a good thing to do across all of our counties, all islands. So we've got an initiative, Big Island and Maui, where crisis provider has been identified as providing the mental health emergency worker staff, and we're on the verge of designating the facilities on those islands. Kauai is different. Our plan is proceeding there with the Kauai Police Department and the 3 facilities on Kauai that have emergency rooms. As you well know, and as you know better than I, our counties are very different from one another. Our hospitals are very different from one another. What works on Oahu isn't going to work on Big Island, and our programs are in very different stages of development. So we've been working through that, and we're making, I think, good progress. It's not done yet. This spring will show a lot of further formalization of the designation, both of mental health emergency worker and of MH1 receiving facility.
And with our expansion of telehealth, I'm hoping that our premise is that all hospitals in the state need to be capable of at least assessing, maybe with some telehealth support from some other hospital, any patient that comes into the emergency room, and they may need to triage from there, but it shouldn't be a diversion. Everything goes to Queens and Castle. So we're dealing with that.
Well, I'm glad that you mentioned some of the services on the neighbor islands, because I was scrolling through and I can't find it again, but it looked to me like there were some disproportionate cuts in services that are servicing Molokai and Big Island and Kauai, maybe even Maui. So I'm wondering if you've broken down where the cuts are impacting to see that we're not, because a small cut to a neighbor island service may be the difference in whether that service is going to be able to survive or not. I just want to make sure that all of our areas are being serviced appropriately and we're not disadvantaging anyone because either funds have been restricted or we're facing other kinds of cuts. I just want to make sure that we're keeping true to, we want to make sure that all of the folks in Hawaii have access to the services that they need.
Absolutely. In fact, as Dr. Fridovich and Director Pressler have indicated, we are expanding on the neighbor islands, not only for areas like special populations like the homeless, but also through this MH1, MHEW effort, never done on the neighbor islands. So we continue to look at the neighbor islands. Our budget request for the CMHCs and the positions is broken down individually by counties, so you as legislators can see the impact to the neighbor islands county by county. So those are some examples, and we acknowledge there's more work to be done, but we definitely are looking to not just be Oahu-centric. Okay.
I guess that would be the restriction on the public health nursing branch, because that says that affects all rural areas of those islands.
That is not necessarily mental health, but we'll get Danny up here to address that.
Good afternoon. Danny Wong Tomiyasu, Deputy Director of Health Resources Administration. I'm sorry, Senator, could you repeat the question?
I guess the restriction was 8.6% of the total amount for the public health nursing branch?
Correct.
And then in the impact, the last sentence says the limited staffing will impact all communities, including rural areas of Big Island, Molokai, Maui, and Oahu. So what are we doing to make sure that we can mitigate some of that?
We're in the process of putting together requests for some of that restriction back so that we can mitigate some of that impact.
Same time that memo's going up, I guess. I guess I had a follow-up question on the diversion, though. Some of those community hospitals or community health centers, they may not have the proper facilities for intake. And I guess when I went to see Queens, knowing that some of those hospitals or community centers don't have those facilities, are they going to at least be applying for GIAs? Like CIP, GIA, so that we can actually help some of those health centers and community hospitals. So they have the right ability, they can have the ability to intake those patients.
Well, I'm aware of some of the challenges in our smaller facilities, again, especially on our neighbor islands, and in particular the predicament facing some of our critical access rural hospitals. So we're sensitive to that as we roll the program out. And that will be taken into consideration with the designation, in terms of the designation as to under what circumstances will an individual presenting with emergency and meeting the criteria for MH1 required transport. We haven't thought through the issue that you're raising, so thank you very much. And we certainly will be prepared to raise it with the hospital colleagues and our hospital partners when we meet with them again, especially if there are CIP or other grant and aid proposals that may address the needs that they've got in serving this population.
Well, the deadline is in a couple weeks.
Yeah.
Okay. Well, and the other thing, too, that is sort of a corollary to this is what are we doing to help build capacity either in our community hospitals, facilities, or among the providers of services, the EMTs, the police, so that they know how to recognize and can help guide. I know we have a really, I think, stellar emergency services branch that is part of moving people around, but I'm just wondering if we're getting the training and some of the other kinds of backup to some of these providers so that they can make an intelligent diversion.
Right. That's part of the...
Yes.
Senator Baker, Senator Dela Cruz. As we looked at facilities, especially on the neighbor islands, one of the first questions we asked ourselves...
Well, don't forget rural Oahu.
And rural Oahu. What are the hospital? Many of the hospitals and the providers, they already are likely already serving this population. Because if someone is in crisis, where do they go currently? So as we looked at the MH1, MHEW, and other areas, we thought, well, through this effort and the designation, we can offer some training resources to build capacity. As we move forward in this area, we acknowledge there may be issues around facilities and security that come up. And, we're very sensitive to that. But it will definitely build on what they're already doing, because they're already having to serve this population. It's just designating them so that we can, in fact, provide some resources to help build capacity and sustain the effort.
Dr. Rosen, some of your hospitals are ones that we've been talking about with regard to capacity. What are you seeing from the HHSC in terms of impact?
Well, thank you. As has already been described on the neighbor islands, we're generally the only providers, geographically have been for the most part. So those individuals who would be designated MH1, which basically means their right to refuse is taken away and they're mandated to be sent for evaluation, are being evaluated. The challenge for hospitals that don't have inpatient psychiatric services is they don't have psychiatrists. They don't have psychiatrists on call. That stopped many years ago. Community hospitals don't have psychiatrists, and they don't have the kind of secure environments, places where these types of patients can be isolated from the mainstream emergency department. Those are the biggest challenges, and although telepsychiatry could mitigate, there's a lot of facility issues that come to bear on the smaller community hospitals as well that aren't easy to fix. So part of the concentration of these patients in facilities that have psychiatric services is actually with good reason. And when additional hospitals were named for MH1 on Oahu several years ago, it was not successful for that reason, and the police figured it out pretty quick. So the police are very instrumental here. They want to go where they're the individual is going to be quickly assessed and triaged and receive definitive care. It's not helpful for them to go to a place that can't basically take care of it. They end up being transferred to the psychiatric facility anyway. So the thing is to really dialogue and make sure we try to come up with the most helpful and efficient system given the resources that we currently have.
Yeah, and so that's why we're working actively with the Healthcare Association of Hawaii, all the hospitals at the table, so that we can address, is it a facility issue? Is it a psychiatrist issue? We can do the psychiatry to a certain extent with telehealth, but there may be facility issues. There's not a secure ER bed that they can take some of these patients. So that's all part of the process.
Watch them. Because it's a very serious responsibility on the part of the hospital. They're brought there because they may be suicidal or homicidal. That's the reason they're under MH1.
Senator Spiro.
Actually, just to follow up on some of the discussion, are you able to provide us a listing of the providers that are doing the homeless outreach with for drug addicts or drug treatment, as well as for mental health? Can you provide us that list that we're funding?
We'll work with Alcohol and Drug Abuse Division and Adult Mental Health to send you a list of those providers that we contract for those services.
And the discussion on the mental health patients, and Lynn and Ed, we've had this discussion, but our clean and sober law, where a home can take up to 8 patients. No, Doc, this is for you. Would that be an alternative for that population if we were to amend the clean and sober law, which is right now geared towards substance abuse? But if we could do it towards and involve mental health, that might open up some opportunities.
I thank you, Senator. It's actually not my area, but thank you. So I can't comment.
Right.
But perhaps,
Eddie, would you like to join me? Thank you. Generally,
mental health.
just as if I could, Senator, excellent question. Once again, over the years, the LEG has supported us in developing clean and sober homes and making a commitment to improve the quality of clean and sober homes. So you funded a registry. We do have a proposal for you to make it a permanent function via a position, and that is one of the Form As we presented to you. Specific to your question, coincidentally, we were just discussing this yesterday, and and Eddie, please feel free to add. Currently, someone who might have a co-occurring disorder and have SMI, severe mental illness, or just, milder form of mental illness, and can't access clean and sober homes. The big, I think the part of this is if the individual chooses to continue to consume alcohol, then they wouldn't be eligible for a clean and sober home. So we're kind of talking about kind of this area of housing and housing first, which I believe the administration is looking at, that these individuals might be able to go to to meet their housing needs and to continue to receive wraparound services that are needed. You want to add anything?
Yeah, just to piggyback on, hi everybody, Eddie. Just to piggyback on what Lynn said, the two main points. One is that people with mental health issues can access clean and sober housing as long as they're willing to abide by the standards of that clean and sober housing right now. And secondly, part of the challenge with clean and sober housing is that most of them, actually all of them, require abstinence for people to reside there. So that's a narrow, especially when you have people with co-occurring disorders, that's a narrow population. What we're working on is increasing that spectrum so that there are clean and sober houses that require abstinence, and then there are other homes that will work with individuals who are struggling with addiction, because relapse is a part of that addiction, right? And so what we're looking at in the next couple of years, especially with the additional funding that we got last session, is to, number one, expand the capacity and the inventory of clean and sober housing that we have. And the providers, we went from one provider last year to now 4 providers, going from about 28 homes to almost 40 homes that we'll be able to support, and to, again, increase that spectrum so that we have homes that will accept people who are not necessarily able to maintain abstinence, but they'll work with them as long as they're in treatment, that kind of thing, and then also the abstinence base.
And you could expand that through your department. You don't need any HRS from watching this.
Not that I'm aware of, no.
And it may be that as you look at the spectrum of how, so once again, it goes back to how we align and coordinate and link and sync our resources.
Right.
So there may be another entity within government that provides the housing, and there may be subsidies through rapid rehousing. So the question really is, how do we work with those housing entities to provide them the treatment services or other services they need so they live successfully in that housing setting, and help them move until they're able to be more independent.
But we're also talking about property owners and landlords who may want to convert their homes into this little niche market, correct? When you talk about the need for the housing facilities. I'm not a housing expert, and I would assume that hopefully in our community with its goodwill, that there would be landlords and landowners who would be willing and open to providing and making their real estate available for serving this population. Because there is government funding that would go with the patient, is that correct?
Yes.
Under our contracts, yeah.
So just like a caregiver or, like I said, an existing clean and sober, the ones you have now, I mean, this is an opportunity where we could take our existing houses that are out there owned by individuals and convert them into these health facilities for the mentally ill, for the drug addict, for whatever the case may be.
Yes, but not quite as simple. So one of the things that we have to be careful of is not to on the one hand, not to try to regulate clean and sober homes too much because they don't get into Fair Housing Act.
Right, I mean, federal laws protect these individuals
Correct.
who want to live in these homes.
Absolutely.
You know,
So-
and a neighbor can't say, no, we don't want you there.
Correct, correct. And that's the flip side of the coin is the other piece of it is to work with not only the clean and sober home operators, but the communities that they live with, that they have their homes within, to be able to kind of be better neighbors and be more interactive with their neighborhood. And that means working with those providers, not to just open a home and stick 8 people into the home, but to really create a place where the community at large can recognize that this is actually a benefit.
Oh, I mean, we would have to do it right, do the outreach, do the discussion, make sure everyone understands that this is a segment of the population that could hit any family or anyone at any given time. Thank you, Chair.
Senator Young. Thank you. I wanted to know if, because of maybe new federal regulations, there are some hospitals, particularly the rural hospitals, that maybe have had to close some of their behavioral health or mental health units.
HHSC has been the only provider of inpatient psychiatric services on the neighbor islands for some time until this past year when Maui Health Systems is now operating Maui Memorial, and they have a behavioral health unit. As you may recall, Senator, we did have a closure of adolescent inpatient mental health at Maui Memorial about I believe it was 3 years ago, Senator, right before the law was passed in 2015, I believe it was. And that's the last actual closure. However, I can say we really do struggle with maintaining those services in terms of the coverage, the psychiatric coverage. We've tried to work with the Department of Health on contracts for those services. They do contract for a certain number of beds in several of our facilities, but not in Hilo right now. I can only say that if we are not able to secure the funding that we need, psychiatric services are always in discussion because they definitely are not money makers. We would consider them an essential service to the community, but the numbers of patients that we can actually get reimbursed for compared to the cost of providing those services is quite daunting. We did actually reduce the bed count at Hilo Medical Center, I believe, year before last, by 8, but we have been able to provide for those patients, but recently also East Hawaii is engaging in securing telehealth services for psychiatry because it's very, very challenging. So I can say that under the present circumstances, we are going to continue to provide the service which we have, but it's very challenging, and I can tell you some of the regional boards have had discussions about why are we, having to, if you will, foot the bill on some of these things.
Thank you for that, Dr. Rose. And I think I'm also talking about the facility itself. I visited Waiawa General yesterday morning and had asked why they have a behavioral health, mental health unit of, I think, 10 beds, but they closed the wing, and they're telling me it's because of new federal regulations that deal with facilities. They cannot have this kind of ceilings because the possibility of the patients hanging themselves. They can't even have a TV that has a bracket on it. It has to be recessed into the wall. Even the beds that have the pukas at the end, for whatever reason they are, they cannot even have that. It's just very difficult. So, I think we're going to see several rural hospitals coming in and asking us for assistance in facility renovations and equipment. But you guys have...
Yes, and thank you, Senator, for that. And in fact, we're dealing with that at the Hawaii State Hospital as well. New requirements regarding potential hanging. You can't have a hook anywhere. You can't have a door, a window that opens that someone might be able to hang themselves from. So I don't know if Lynn or Ms. Bill Maher, Bill can address. We're very concerned about that at the state hospital, the new federal regulations, which are extremely stringent.
Hawaii State Hospital was just reaccredited from a national entity, JCO, for, is it 3 years? 5 more years? And in fact, they were just out yesterday and commended Hawaii State Hospital for all the work it's doing. We're very pleased. Specific to your question, in their recent visit several months ago leading to the reaccreditation, what they identified as one major area that's very costly is called ligatures. And I'm going to let Bill May, who's the administrator, go over that.
Thank you, Lynn. Bill May, the administrator of the Hawaii State Hospital. CMS, the Center for Medicaid and Medicare Services, they provide the funding for most hospitals. The Hawaii State Hospital does not get our funding from CMS. We get it from appropriations. But the Joint Commission has been delegated the authority by CMS to monitor most of the hospitals throughout the country. And CMS, for whatever reason, I'm not sure what the reason is, are really coming down hard on ligature points throughout the hospitals. There's a major pushback from the hospitals. You could have a building that's been there for 100 years, have gone through 30 triennial surveys, now all of a sudden you're being forced to do millions of dollars worth of renovations to take care of the ligature risks. At the Hawaii State Hospital, we had our triennial survey back in September, and we were told the same thing. And we're looking at perhaps $3 million worth of renovations throughout all of our patient areas to take care of anything from a shower head to a sink faucet to a doorknob to hinges to closures like what you have behind you up there, anything like that where a patient could be by themselves and could possibly hang themselves. Now, the interesting thing is being that the CMS came out very, very hard and the Joint got the marching orders and they came out hard, and the amount of pushback from the hospitals, now CMS may back off a little bit. Unfortunately, we were surveyed during that gray period in between the really stringent standards and what might be a lesser standard. So we're in negotiations now with the Joint Commission to see exactly what it is that we have to do. But it's a major thing. You're absolutely right. You're talking millions. California has major psych hospitals, and they're looking at $50, $60, $70 million worth of renovations for this type of thing. So that's the story.
So was there a grace period as to when these had to be fixed?
No.
Or it was immediate?
It was immediate, and if you did get your funding from CMS, there's no waiver. We were able to ask for a waiver, which would allow us so much time, and we're talking years to do the renovations at the Hawaii State Hospital, which isn't the biggest hospital in the world. If you have deemed status, which means that you get your funding from CMS, you have X amount of time to get this done. Hence the big push, NASHBID, which is a big lobbying group for most of the psych hospitals in the country. They're starting to get involved also with the conversation. But it's a major thing throughout the industry, throughout the country.
Thank you.
Yes, sir.
Senator Armoro.
Thank you, Chair. Can I switch to other topics?
Go ahead.
Okay. Got a couple questions about other things, but first, Director, I just wanted to thank you for your staff's participation in some of these non-traditional areas. The proactiveness and the collaboration is really appreciated. One example is the Oahu Metropolitan Planning Organization. This is transportation planning organization, but having the Department of Health at the table and having a seat at the table is so helpful. And I just wanted to commend you. Your staff is doing an excellent job in just promoting a health perspective on what we normally wouldn't think is health. And it really promotes or creating a culture of health for Hawaii and taking health to people live, work, in every place. So I just wanted to thank you, and I'm hoping that we can do more of that in the coming years. So thank you.
That's our intent. Thank you. And you know, we've got to put health into aspects such as transit-oriented development and complete streets and those kinds of things. It's the only way we're going to start moving the curve on the diabetes, renal failure, and dialysis problem.
Yes, thank you very much. First question is relating to the ambulance issue. You know, I know that we've tried, or you've tried, counties have tried to fund additional ambulance. You know, population has grown so much, but we seem to struggle to get additional ambulance services to keep up. And I saw the special on TV in November that did a really good job of bringing the story to the public about why we need, urgently need more ambulances. You know, things like, I think they said there's an average of 15 calls per day, you know, for one ambulance, and they followed the crew around. They couldn't even wind down for one call before they had to jump in for another call. With that stressful work, and you know, this turnover and relatively low pay. I think one of the other things was you could compare Boston with one, and Boston with a population. I just got this from the news clip, but Boston population is 650,000, and they have 35 ambulances. And Honolulu, you know, I think they said something like 20 ambulances. But anyway, you know, it was a stock comparison. And I wonder if you could just share a little bit about the dire need and how we can address that.
Thank you, Senator, for that question, because there is a tremendous need for emergency medical services in our state. And it has been a challenge because the state has a large investment in ambulance services for the citizens and for the visitors of Hawaii. So approximately $88 million of state funds and special funds go into the cost of ambulance services in Hawaii. And the department collects about $42 million, so about half of that is returned back to the state treasury. So we do recoup about half of those funds, but there is a tremendous need. One of the challenges are that we continue to need to meet the collective bargaining requirements from all the counties. And that has been our primary concern, is really to maintain the level of services that we currently have. We don't want to diminish those services in addition to needing more ambulances as well. What I want to do is have Dr. Bronstein, who's the chief of the EMS branch, to share the work that he has been doing with the counties to identify where the greatest needs are for ambulance services.
Thank you, Dan. Hi, Chair Baker and Art Motel. I'm the EMS Injury Prevention Branch Chief Al Bronstein for the state. We have been working extremely closely with the 4 counties and the agencies in those counties that provide emergency care, the 911 service of the state. And we have monthly meetings. We work very close, and we've been able to identify where the needs are for new ambulance units. The 911 system is a very high-tech system, so high-tech is expensive, yet that's what we have to have, as Danny mentioned, both for the residents plus the people who visit Hawaii, because we have the distinction of wherever one is in Hawaii, they can get a 911 ambulance, and that's very important to the visitors as well to the residents. Each county is a little bit different. We've been extremely sensitive to the needs of all of the counties. We have identified the counties where we need new units, and I've been here about 2.5 years, and every year we have made our case, but unfortunately for the past 2.5 years, we were not successful. We'd like to see that change. We are a unified group. I say unified with the stakeholders, which are the ambulance agencies. They all come together work together to help each other, and we make a unified recommendations for what the state needs. Right now, the largest areas of needs for new units are on the island of Oahu, Big Island, plus Hawaii. So that would be at a minimum, we need 3 new units. And we feel this could better serve the population.
So on the special, so all I know is what I saw on the special, but they talked about the response time standard, and that we met that standard only 70% of the time, if I have that correct. So what is that standard, and I mean, do we interpret that now as meaning that 30% of the time you don't meet that standard, that means there's a risk that somebody might die?
That's essentially correct. We don't always meet the time standard for the 20 minutes, let's say, response time. We are putting in place some things to help that, but the core issue is felt to be we need more units on the streets. In Honolulu City and County, we have 20 ambulances that are on at any one time, and I think most would agree that's probably not enough. And because of that, the city and county has been able to marshal other resources, but it doesn't substitute for the fact that we need more units in the state system. And when I say state system, it's really a partnership between the states with Hawaii's, with the counties.
Okay, thank you. That's something I think we all should do. Certainly, hopefully we can address that a little better this year.
Thank you.
One more question, a different area. Okay, so the question related to, I think, folks probably know, I was going to bring this up, the Red Hill Navy Field storage.
All right, it's Keith Powell.
Yes, Keith, we all going to bring this up, I'm sure. People in our West Side districts, we're really concerned about this. As you know, we've been harping on this. The Navy keeps repeating this mantra that our drinking water is safe. The test shows it's safe. But our comeback always is, at the time you detect contamination, it's too late. And many of my constituents keep complaining that we don't believe the Navy is moving fast enough. And I know that there was this agreement, but 20 years is a long time to come up with a solution. Is there anything we can do to speed up the Navy's response?
Thank you for that question, Senator. And I think we've talked about in other times too. Keith-Agaran, the Deputy Director for Environmental Health. You have two competing high-value needs. You have the protection of the environment, which is the protection of our drinking water and water resources, as well as national security. Those don't normally always are compatible. In this case, they may not be. The Navy has asserted that, and we also are asserting that the water is safe to drink. Even water supply asserts that too. But because of that threat, and that's what you're alluding to, that you have right now 18 12 million gallon storage tanks sitting just on top of aquifer, the lava shaft and the Red Hill shaft. There is that threat. It's that risk that it could be a release, maybe small, maybe large, but there's that threat. I think with the administrative order of consent that has been signed now about 2+ years ago, the Environmental Protection Agency, DOH, as well as the Navy are working toward those tasks. The immediate one is how do we upgrade the tanks that are already there. The Navy has provided a report to us to look at 6 options right now. And the Navy has not recommended one. They're looking at that information as well. In fact, we're going to have with the Navy probably an informational meeting probably in about 2 months to kind of go over it in more detail, what that report contains. Based on that information, they will actually recommend to the regulators what option they select. We will have the ability to look at those options and make our determination whether it's acceptable or not, at least for the first 4 tanks. the 20-year question has always been out there is because in order to maintain operational capability, the Navy can't just shut down all the tanks and do one big upgrade. They have to maintain some level of capability to supply fuel, both for the Navy ships and the Air Force planes. And we're kind of in the middle of that. As regulators, we understand that, but we also want to protect the environment. So I think we're working as fast as we can, all the parties concerned. It doesn't satisfy all the public regarding that, but that's what we're working toward.
Yeah, I fully appreciate your position and thank you for your efforts. But I have to say that it just doesn't cut it out. I'm not meaning you, but in the situation. It's been 5 years since we had that started this whole thing. And in 5 years, now we're at the point where we just have the report of options. I'm just not satisfied with that. But I just want to put that on the table that our drinking water, our pro-harbor aquifer is at risk. And, it's just a situation that I think many of us are just not willing to tolerate. But thank you. Thank you.
Thank you.
Thanks. Can I follow up actually on the EMS question? Sorry not to make musical chairs here when people come back up. But I know for the last few years we've been looking at the sustainability of some of your funding. It started with IRF and having to move you all from special funds to general funds. It's been in the news lately too. We were actually watching the energy offices because we knew they were going to go belly up at some point and not be able to sustain themselves. But we did a report, I think, DOH did a report to last year's session, I think, looking at options for cigarette tax, right? And I think there was actually some attempt to try to move some of our trauma and EMS special funded programs to continue that process of moving from special funds to general funds. Because we knew the sustainability of both the trauma fund and EMS special fund is waning, right? When we take a look at the projections from the past few years, especially this year, and we look out the next 10 years, we're decreasing by at least $1 million, maybe $500,000 to $1 million every single year. Because you're doing a good job. People are smoking less, right? Probably driving cars less, doing all kinds of things because motor vehicles, registration, other types of traffic incidences all go into these particular funds. But that being said, all of these things start to deplete the funds. What happens as a result too, we have to then subsidize with general funds. So in addition to that, I know this year, I think, $2.8 million is being requested for EMS collective bargaining, right? This on top of other additional base funding additionally we've had to add in for collective bargaining in the past and we've come in for. So there was a request at one point. I think the report even suggested that whether it was by this year or so, we move EMS completely to general fund. I think that was at one point the discussion. Even at some point looking at just, to me, a broader discussion of how do we use trauma fund. We're having a discussion even about, I think it was the trauma centers or the hospitals that take in our dual diagnosis patients, homeless and mental health patients. Do they need assistance of some sort? Where are we going to find the resources to do that or whatnot? If we have a viable trauma fund, could that even be potentially one source of revenue? Because remember, and you folks know this, we pay those trauma centers out of our trauma fund. We can't even get new trauma centers online unless we have a viable trauma fund. And that was a discussion I think we had last year too. Can we bring online new trauma centers, right? But with a decreasing pot, we couldn't even consider those particular options. I think Queens right now is a trauma level 1. And that's, they're number 1 now, right? And that's about, $1 million plus a year, at least in terms of reimbursement rate, right? But whether or not they need a little bit more to accept the kind of patients that they do, who knows, but we can't have that discussion if a lot of it's also being used up for the reimbursements for EMS. So are we looking at these kinds of discussions about whether or not sustainability of some of these special funds are just not happening, and whether or not we as a state have to move to general funds? Or in the past, the discussion has also been had whether or not the counties have to also be brought into the discussion as well. That's never a fun one that the counties like to have. But that is something that has been discussed as well, especially if counties also know best where the priorities might lie in terms of where the additional buses might come into play, because I think one bus plus the staffing for it annually is approximately $1 million, I believe I want to say, right? But, you know, again, given that this report was done last year and we talked about all three of those funds, trauma, EMS, well, those two funds, even the community health centers, although I think we moved them off already, or at least capped them. All of them were decreasing significantly in their sustainability over the next 10 years, which means we're going to continue to have to subsidize them in the millions of dollars. So we have to have that come to Jesus moment about what we're going to do, either full conversion or what, or understand that we will have to keep plugging in these additional funds every single year. You'll have to make those requests to us. So
Thank you, Senator. Yeah, I mean, we were supportive of conversion from the special funds to general funds last year, but that bill didn't make it at the end,
I think
so
the
I don't
administration
know.
also pulled out, the governor also pulled out of his support. I think the
No,
the department
we
made
were
the request
pushing that. We
in
were
your
fully-
budget, I believe, but I can't recall if governor kept it in the final
It was
budget.
not in the budget, but it was an administrative bill. And I think what happened during the session was that particular bill was very specific at moving the EMS special fund onto general funds. But during session, many other issues got attached to that bill, which there was not consensus or agreement on, so I don't think that bill moved forward.
So regardless, yes, we've addressed that. We are willing to look at options. We need to go beyond just moving from special funds to general funds. We probably need to look at additional sources of revenue. And I don't know if you two have additional thoughts on how we sustain this long term as far as revenue sources.
I think the one thing, we have to discuss this amongst the group, and there are various ideas. There's not one clear option. I think we could, personally, I think we could do something more with the monies that we collect to help offset some of the increases. And that would need to be looked at more closely. The trauma fund, just to clarify, does not go to EMS. None of the trauma monies are used to support EMS. Just to clarify that. I think we worked really, really hard farther to make the collections for veteran services. I think we've seen we are doing very well, and I think that requires not only the work of the people who do the billing, but it goes back to the field personnel to collect certain information. And so anything we can do to enhance that, I think will go a long way to help the amount of funds that we can collect. It goes back into the general fund, but if we could see some of that back, we could maybe pay for some ambulances, and it would be less painful to the government in general, because the money was already spent, and we're lucky that we can give money back, which is great. We're looking at ways to give back more money. For instance, we currently don't take credit cards. We want to move in that direction, so we can take credit cards. That's important for people from out of state and from out of country. So we're looking for new ways to enhance those revenues.
Dr. Donovan, how much of the EMS services is reimbursable through insurance?
It's probably, we have some that's not, but it's probably 70% plus reimbursement.
I think just in general, we're looking at some of your funds that have not been sustaining themselves, and we've had to supplement, but especially since the conversation is specifically on EMS, and there was a move to take a look at whether or not we have to fully look at a general fund conversion for this, where we can have a constant discussion about what's going on with this and make decisions like to add buses or whatnot, or even to even have a much more radical discussion as to whether or not there should be even county participation. as well, so that there can be very home rural discussions as to adding additional buses or not, and additional revenues tossed into it. I think that's something that can always be potentially looked at. I don't know if you folks have entertained those discussions at all, but I think at one point, all those ideas had been put on the table, especially as we saw that the resources were constantly dwindling down, and with collective bargaining costs, we were having to continue to put millions of dollars in just to even cover the bare CV costs versus even being able to first even consider additional buses. I think everyone wants to consider additional buses because you don't like to hear that you're only making those times, you know, a certain percentage of times. No one ever wants to hear those kinds of things at all. But at this point, the state was barely even being able to maintain the collective bargaining costs that were being, you know, negotiated. So have we actively been engaging on taking a look at the sustainability of the funding, or is this something that has come up with the budget requests right now?
Well, as I said last year, we were willing to make that transition from special funds
but
to
in the
general
interim, no
funds.
discussion has been taken in terms of looking at sustainability of funding and where we could actively look at additional funding for more buses, I guess. I guess the next question, since I know I've asked probably too many than I should, if I could just move on to the Hawaii State Hospital. And I know we'll have a broader discussion on security, but don't worry, it's not on that. Yeah, ambulances. Oh, we're not putting them in real buses. This is an ambulance. Okay. We knew what you're talking about. Don't worry. We're not that shortchanged. We're not going to give them a bus. Yeah. Times are tough, but you don't have to catch the bus. Okay, sorry. Real quick, Dr. May, in terms of the overtime, I was looking at the projections. Looking at what you've got projected for fiscal year 19, is that really realistic in terms of what you have down for fiscal 19? I know that you folks have been working really hard to try to reduce your overtime projections, and you've been trying to manage it for quite some time. I think we gave you $6 million back in fiscal 17 to right-size your budget a bit. I don't think we gave anything last year in terms of additional funds, but we've been building up your base here and there so that you didn't have to cockroach any money from community-based mental health as much as possible. But taking a look at your actuals for the state hospital, you had a 9.7% overtime amount. That's about $3.3 million for fiscal 17. Looking at 18, what you have projected, that's $3.6 million, 10%. Looking at what you have projected for 19, you have $951,000. How realistic is that? Because if it's not realistic, then you're going to be at a shortfall again if you're not asking for additional monies for the state hospital, and then you're going to be cockroaching money again, likely from your brothers and sisters in community-based mental health.
Yes, Senator, thank you for that question. Actually, Lynn and I spoke about this yesterday. If you look back over the budgeted amount for the past several years, it's the exact same amount of money, the $951,000. It's not what we're going to spend on overtime.
Yeah.
It's going to be closer to the
3.6 million.
3.5, 3.6 million. So, no, it's a great question. We're not going to get down to below $1 million in overtime.
And that's always obviously been a problem with the staffing. Obviously in the OT, we've had that discussion as well. But if it is going to, if you do have to reinsert that number for the money committees that are going to have to understand what your budget actually looks like and what you have to work with, if you put in 3.6 million there instead of 951,000, then are you facing a deficit situation with your budget, or do you have the means within your own program ID to be able to manage 3.6 million in OT, or are you going to be taking from probably Ed and, you know?
Well, I'd like to thank Eddie in advance.
Which we don't want, by the way, because if he does his job, he won't show up at your door. Everyone won't, you know.
No, exactly. It's exactly true. No, if we don't correct that number for the for that fiscal year's overtime projection, it will be short, and we can correct that.
Okay. You know, I think that would probably be helpful for all of the committees both health as well as the money committees, to know whether or not, even if you backtrack to fiscal 18, because we didn't give you additional funds, I believe, to help out your budget for any projected deficits. But if you still had $951,000 last year too for your estimated 18, and you're at 3.6 million estimated for 18, and we didn't give you additional, and you're short, so it, it compounds, deficits. So I think what's really important, and we had, again, this discussion the last few years about right sizing a budget, which has been a constant process, but, and OT is always the issue, because it's one of those uncontrollable costs. Yes. And we know that, but I think at the end of the day, granted, you can't keep coming in for $6 million of help every single time to try to right size it, but so you don't go stealing from community-based mental health or, alcohol and drug. How do you make sure that the money committees and the subject matter committees know exactly how much you're short, compounded over the last for at least the biennium on the OT, because that's probably your biggest outlier, if I had to guess, for your costs.
It's definitely one of the biggest outliers, and it goes about 9.5% to 10% of the salary budget will be allotted towards overtime. We keep our vacancies filled. Our fill level overall is about 92%. Direct care is very good. RNs right now, we only have 3 registered nurse vacancies. PMA and psych techs, at one point a couple of months ago, we had 0 vacancies. So, we keep our positions filled as much as possible. We do have an issue with hiring psychiatrists, which causes us to use local tenants at a cost of about $130,000 more than what a full-time psychiatrist would cost. So there's other issues in there, but the projection for this year was actually only around $300,000 short until some added costs that came up because of what happened back in November. So now it bumped up the deficit a little bit. But we will meet with the staff of the both this committee and the House Finance Committee. We have met actually with the House, but we've yet to meet with this committee staff, but we will, Chair.